Hi everyone. In today's video, I'm going to be going through the different types of cardiomyopathy. Now, you better be ready because this is going to be a very long video because I am going to talk about the three different types of cardiomyopathy as well as the different subtypes that exist within these three types. So, before we look into the details of cardiomyopathy, I first want to introduce to you what the term cardiomyopathy actually means. In general, cardiomyopathy is not really a good word to describe what these conditions do because it's a very generalized term. Cardio relates to the heart, myo relates to the muscles, and pathy is that there's something wrong. So literally the definition of cardiomyopathy is something wrong with the muscles of the heart or the myocardium. And although that does sort of define for us what happens in these conditions, it doesn't really give us the details. So to allow for a greater specificity when we're describing to a patient or when we're trying to define or diagnose what a patient is going through, we use three categories to see which type of cardiomyopathy the patient is suffering from. The first type is dilated cardiomyopathy, and that is pretty self-explanatory in what we may see on a histological sample or macroscopically when we're looking at the patient's heart. If the patient's myocardium is dilated, then that essentially means that the ventricle size or atrium size has increased, so those chambers of the heart can carry a greater volume of blood. And it could also mean that maybe fibrosis has taken place or the actual myocardium itself has atrophied and therefore the walls of the heart have become thinner. The next type is hypertrophic cardiomyopathy, and this is essentially the opposite of dilated cardiomyopathy in that we can have a reduced lumen size of the heart, which means that there is a reduced ability of the heart to carry blood, and as this is a hypertrophic condition, there is an increase in the thickness of the myocardium, which means that the person may be suffering from conditions such as hypertension, and it can be exacerbated if the heart muscle thickens even more. The last type of cardiomyopathy is called restrictive cardiomyopathy, and this cardiomyopathy is a little harder to describe or define, but essentially it relates to a restriction in the ability of the pumping action of the heart. So this can be once again due to fibrosis, and there can be contributory factors from hypertrophic and dilated cardiomyopathy contributing to restrictive cardiomyopathy. So let's firstly get started by exploring dilated cardiomyopathy. So dilated cardiomyopathy has two different types, and the first type that I'm going to be talking about today is idiopathic dilated cardiomyopathy. Now, idiopathic, if you've ever encountered this word before in other conditions, basically means that we can't describe or we don't know the cause of this particular condition. So when we say a patient has idiopathic dilated cardiomyopathy, we know that there is some sort of dilation of the myocardium occurring, but since it's idiopathic, we don't know what's actually causing this. Idiopathic, once again, if you've seen my video on the vindicate mnemonic, is part of whenever we make a differential diagnosis. So, as I've already described, idiopathic dilated cardiomyopathy can have many different causes. And usually familial causes equate for 1/3 of the cases. So as you can see, this is usually an inherited condition. 1/3 of the time we see that there is a history of dilated cardiomyopathies with the patient. And if you're wondering what the inheritance pattern for this condition is, there are many patterns, but usually what we see is it has either an autosomal dominant inheritance pattern, autosomal recessive, or it can be X-linked recessive. So as you can see, its inheritance in terms of a pattern is not very specific, but if you have a patient with dilated heart conditions, then you can, if you want to try and confirm the diagnosis, see if the patient also has a family history of such conditions. Now, since this is a familial condition, and as familial conditions usually relate to genetic conditions as well, there are some particular genes that are affected, and mutations on these genes can cause for idiopathic dilated cardiomyopathy to occur. So these genes include troponin T. Now, troponin T is a gene, or can be used as a marker after myocardial infarction, and if we see elevated levels of troponin T within a patient, then we can say that they have had a myocardial infarction recently. Troponin itself is an enzyme within cardiac myocytes that is essential for their function, and very, very, very minute levels of troponin are found normally in a person because cardiac myocytes are constantly undergoing repair processes, even though they're not necessarily undergoing any replication. But if we see the presence of troponin being greater than 0.04 nanograms per milliliter of the patient's blood, then we can see, or maybe even confirm, that they have had some sort of heart event that's caused destruction of the myocardium. Other genes that I won't be going through in this video, but are important, include, or are a part of the cause for idiopathic dilated cardiomyopathy, include beta myosin actin, laminin, and desmin. So if you are suspecting a patient has idiopathic dilated cardiomyopathy, then you can order genetic tests to test for these 4 genes. And pretty much we say that when you're diagnosing a patient with a condition such as this, you do really require testing these 4 genetic mutations just to ensure that you have the right diagnosis and you've confirmed that the patient actually has this condition. So the next type of dilated cardiomyopathy is called secondary or toxic dilated cardiomyopathy. And this condition is not as common in terms of a genetic cause as is seen with idiopathic dilated cardiomyopathy, because in this case we usually do actually know what's causing the condition. And the main, if you like, teratogen or offending agent that causes this condition is alcohol. So alcohol is the dominating factor that is directly toxic to the heart and can cause secondary or toxic dilated cardiomyopathy. Other aspects can include cobalt consumption. If the person is suffering from a condition that causes catecholamine sensitivity, so the catecholamines are substances such as noradrenaline or adrenaline and other substances that we usually associated with a stress response. If the patient consumes cyclophosphamide, anthracyclines, and this is assuming that they have some sort of sensitivity to these, or if the patient is a cocaine user. But by far, the main agent that causes secondary or toxic dilated cardiomyopathy is alcohol. So in this case, if the patient is a heavy drinker, and usually heavy drinkers may also present with other conditions as well, so taking in alcohol history is very important. And if they also present with cardiac conditions, and if you perform an echocardiogram and you see that the wall of a particular heart structure is dilated, then you can attribute that to secondary or toxic cardiomyopathy. Now, I want to stop here a little bit and talk about alcohol in particular, because I think alcohol is one of the most direct offending agents to the heart, and depending on its consumption, it can both be beneficial and destructive. And this is quite new evidence that has come out, and it's not widely accepted yet, but various studies have shown that long-term and moderate consumption of alcohol can actually have some sort of a protective effect on the heart. That being said, if a high consumption of alcohol is present for a long period of time, then this has been implicated with left ventricular dysfunction, and it can be present and in as many as a third of dilated cardiomyopathy cases. So this is secondary dilated cardiomyopathy. So in review, if there is little to moderate consumption of alcohol for a long period of time, it may be protective, and once again this evidence is not well supported yet. But if there is high consumption for a long period of time, then this is attributed to up to 1/3 of dilated cardiomyopathy cases. So as you can see, as opposed to the other etiological factors, alcohol has quite a large effect on causing various heart conditions. So now that we've covered dilated cardiomyopathy, I want to move on to the second type of cardiomyopathy that we see, and that is hypertrophic. And hypertrophic cardiomyopathy can be also called hypertrophic obstructive cardiomyopathy, and you may see the mnemonic or abbreviation HOCM, HOCM, which stands for hypertrophic obstructive cardiomyopathy. So this is just something to keep in mind when you are reading maybe patient notes. So as I've mentioned before, hypertrophic obstructive cardiomyopathy is when there is an enlargement of the myocardial tissue in the left ventricle, usually near the outflow tract. So the outflow tract is where the left ventricle leads out of the heart, and it's where the aorta starts. So if there's a problem happening here with the outflow tract, then it makes sense that in these patients we may see other conditions related to heart valves, maybe a stenosis problem, or regurgitation, depending on how severe the actual hypertrophy is. But since there is an enlargement, what we will definitely see is a larger heart, and possibly as well a reduction in the lumen size of the heart, which means that the heart is not able to carry as much blood as it would be if it was a normal heart, but at the same time, it pumps out that blood with a greater force. So the thing about hypertrophic cardiomyopathy is that it usually starts off as being asymptomatic. And that's the case with many conditions that cause either hypertrophy of the heart or any heart conditions, because as seen with hypertension, people who start off with having hypertension don't usually experience, especially with benign hypertension, don't experience any negative conditions. But over time, what can happen is that if there is, for example, enlargement of the septum of the heart, then it can result in asymmetrical hypertrophy, which means that there is compromisation of the filling ability of the heart, which means that the person may feel more tired, they may feel short of breath because the heart is unable to work as effectively to pump blood around the body. And essentially, after that point, there can be systemic complications as well, because if the heart is not working, then the rest of the body is not receiving enough blood, which means that ischemia can occur, and there is the real chance that multiple organ failure can occur over time in that patient. So although this condition starts off as being asymptomatic, it can lead to serious systemic complications. Now, I mentioned that hypertrophic cardiomyopathy results in hypertrophy of the septum, and this is actually a quite common place where we do see these enlargement of heart structures, because if we think about the septum of the heart, not only does it come in contact with the right ventricle, but it's essentially where blood flows into and knocks against when the left ventricle is filling up with blood. So it makes sense if the patient has high blood pressure that the septum will try to increase in its size to allow for more blood to be pumped out of the heart with a greater force, since there is a greater pressure that it has to work against. So in this case, we actually see 2/3 of hypertrophic cardiomyopathy cases as having asymmetric septal hypertrophy. And the problem with this hypertrophy being asymmetric is that, as with any structure, if a particular part of it is more hypertrophy than the other, it's going to cause for a turbulent flow of blood. So this means that there is a greater chance that blood stasis can occur, and that can result in clots forming, or if there is an irregular or abnormal movement of blood through the body, then or through the blood vessels and heart, then there can be conditions such as atrial fibrillation or other arrhythmias resulting as well. So a key clinical finding is asymmetric septal hypertrophy. So once again, to reiterate, this type of hypertrophy is seen in hypertrophic cardiomyopathy, and it's not concentric as seen in the effects of aortic stenosis or hypertension. And the reason why I make that point is because when we're differentiating within how much maybe a particular heart condition has advanced in a particular person, we can say that if we look at the heart, and if the heart has not increased in size in an equal manner, then we can see that this is probably going to be a cardiomyopathy, because a key aspect of cardiomyopathy is if the hypertrophy is asymmetrical. In aortic stenosis, because the aortic valve cannot open properly, then we see an entire hypertrophy of the heart, because the entire heart is aiming to push blood through a smaller opening. But in this case, since it's the actual ventricle being affected, it's not necessary that the entire heart will be increased in size, but rather small parts of it. Now, the thing with hypertrophic cardiomyopathy is that it's quite common compared to the other heart conditions that I've explained so far. Its prevalence is usually 1 in 500, and it's seen to be affecting men and African people to a greater extent compared to other people. And the obstructive form, which is when there is some sort of blood blockage, is seen in 25% of cases, and it's usually seen, interestingly, as the most common cause of sudden cardiac death in young people and in athletes. And you may be wondering, well, why does this occur? It doesn't usually occur because of maybe athletes using the heart more often than people who have a sedentary lifestyle, but usually these people have an underlying conduction system abnormality, which causes for this hypertrophic condition to occur, and therefore sudden cardiac death. So in review, hypertrophic obstructive cardiomyopathy results or starts off as being asymptomatic, but it can cause systemic complications, and its key pathophysiological factor is the presence of asymmetric septal hypertrophy, and unlike hypertension and aortic stenosis, concentric hypertrophy is not seen. Alright, so the last type of cardiomyopathy that I want to talk about is restrictive cardiomyopathy. So as I mentioned before, restrictive cardiomyopathy must have something to do with the ability of the heart to pump blood, and there's something restricting the ability of the heart to go through the cardiac cycle. In this case, restrictive cardiomyopathy relates to when the relaxation of the heart or of the myocardial cells is less effective, and it is associated with the deposition of a particular substance called amyloid. So to a lesser extent, it's seen in cardiac sarcoidosis, but this substance called amyloid deposits within the heart and prevents effective relaxation of myocardial cells. And let's just think about for a second what kind of implication that has for the actual cardiac cycle. So if we think about relaxation, what does relaxation represent? Well, relaxation is seen during diastole, so when the blood is filling within the heart. So if we have impairment of relaxation, then we will likely see that the heart is unable to fill up with an appropriate amount of blood initially, so the diastolic volume will be reduced. And that essentially means that the heart will be unable to pump blood to the same extent outside of it. So essentially, restrictive cardiomyopathy, although it directly affects the ability of the heart to relax and fill up with blood, if the heart is unable to fill up with an adequate amount of blood, well, then it isn't able to pump that blood out, because as we all know, the heart only can pump the blood what it gets. So in this case, although diastolic conditions such as maybe even a diastolic heart failure condition may result, this condition can cause for an entire dysfunction in the cardiac cycle itself. Some of the physiological effects that I've gone through already include restrictive filling and therefore reduced diastolic volume. And the thing is that this reduced diastolic volume can actually occur in both ventricles. On the other hand, since there is no actual problem with the pumping action of the heart, there is a near normal systolic function and wall thickness. Microscopically, we may see some interstitial fibrosis, and that's what may be contributing to the impaired relaxation, because as we all know, fibrotic tissue pulls things closer to each other, and therefore, since the contractility and conductivity of the heart has been lost, there is essentially a lack of proper ability of the heart to relax as opposed to having proper myocardial cells, and therefore there can be the presence of interstitial fibrosis. Now, when we are talking about restrictive cardiomyopathy, there are two types, as we've seen with dilated cardiomyopathy. The first type is called obliterative cardiomyopathy, which is restrictive. And this name may seem a little bit, out there. Obliterative, it sounds very destructive, like the heart's like exploding or something. But that's not really the case with what's happening here. Firstly, obliterative restrictive cardiomyopathy is actually a very rare condition. And it can result from eosinophilic syndrome. So when there's a high amount of eosinophils within the blood, and when you think about eosinophils, you should really think about the presence of an allergic reaction. And essentially what happens in this condition is that there is what we call an intracavity thrombus that fills the left ventricular apex, and therefore, like an inability to appropriately fill the heart, it causes for hampering of the filling of the ventricles. So in this case, if we, let's say, have a look at a cross-section of the left ventricle, if this is the left ventricle, an intramural thrombus, or an intracavity thrombus, is when there is a formation of a thrombotic plaque within the actual cavity of the left ventricle. And what this means is that when blood fills the heart, it's unable to fill to its appropriate extent, because in this case, let's say 40% of the heart is blocked by that thrombus. So that means that an inadequate amount of blood is able to fill, and if this actually occurs, then all of this myocardial tissue here, which is coming in contact with the thrombus, is unable to contract. And this subsequently means that fibrosis of the endocardium may occur, because that particular tissue is not contracting, and this lack of contraction may be preventing it from effectively receiving an adequate amount of blood, which causes the death of myocytes. And so, if we have fibrosis, this fibrosis, since the myocardium is vascularized by specific vessels that cover a specific area of the heart, it can actually extend from where the thrombus is present upwards and spread to valves. And when we think about the various conditions that can occur with the valves of the heart, what can result is either regurgitation or stenosis. Now, this, as you can see, is a condition that builds up on itself and can become quite dangerous. The second type of restrictive cardiomyopathy is called secondary restrictive cardiomyopathy. Now, secondary restrictive cardiomyopathy is actually more common, and it can be caused by many metabolic conditions, and usually when we say that there's the formation of a restrictive condition, it's usually just that there is prevention of the relaxation of the myocardial tissue. There's nothing wrong or nothing unique with the heart going on here, as is seen with obliterative restrictive cardiomyopathy, when there's the formation of a thrombus. The condition is the same in that there is a hampering in the relaxation of the myocardial cells, but the causes are related to metabolic conditions such as hemochromatosis. Other conditions such as sarcoidosis can cause it. Oops, which I just realized I spelled wrong. Sarcoidosis. Once again, as we've seen previously, amyloidosis can cause this condition. And scleroderma. So these are the two types of restrictive cardiomyopathy. Another type, or a type that I talk about not that often, is seen, but I will include it in this video as sort of a third type, or yeah, I guess we'll say it's a third type, but it's important to remember that it's not seen that often, and that's why I didn't initially include it. And this is idiopathic restrictive cardiomyopathy. And as with idiopathic dilated cardiomyopathy, the cause of this condition is not known. So either we have to investigate and see that there are many causes present, or we simply just have to say to the patient that you have this condition, but we don't know what's actually causing it. And that can be quite disempowering for a patient to hear. But idiopathic restrictive cardiomyopathy can be mainly caused by two conditions. The first is endomyocardial fibrosis, and as the name suggests, it's when fibrosis or the deposition of fibrotic tissues occurs in the endocardium and myocardium. Or it can be due to another condition that I'll abbreviate here as LEAD, that's called Loeffler eosinophilic endomyocardial disease. And once again, this has eosinophilic in it, so you can see that it might be due to an allergic or sort of a hypersensitivity syndrome, and therefore these two conditions are most usually seen in idiopathic cardiomyopathy, but usually we don't know the cause, and once again it's quite rare, or uncommon I should say, to see this condition clinically. So in review, restrictive cardiomyopathy is due to the deposition of amyloid within the heart tissue. It prevents effective relaxation of the myocardium, and the two main types that we see are obliterative restrictive cardiomyopathy, which is when there's the formation of an intracavity thrombus, and compared to secondary cardiomyopathy, this is quite rare. But secondary cardiomyopathy is the most common, and it can be caused by conditions such as hemochromatosis, sarcoidosis, amyloidosis, or scleroderma. And finally, idiopathic restrictive cardiomyopathy, which I've included here, is usually when we don't know the cause of the condition, but it can be due to endomyocardial fibrosis or a condition that's called Loeffler eosinophilic endomyocardial disease, and Loeffler is spelled Loeffler. So this has been the video on different types of cardiomyopathic syndromes. I hope you've enjoyed it, and I hope it has all made sense. Thank you very much for sticking with me for over 32 minutes now, and thank you very much for watching.